σας. Θα μιλήσω στα αγγλικά, μιας και έχουμε αγγλόφωνο κοινό. Good evening, everyone. My name is Eleftherios Kazamiakis, and I'm a medical physicist at IASIS General Clinic in Chania. And today I will be talking about the breast treatment planning tips that we're using on our daily clinical routine. I have no conflicts of interest to report. And that's the outline of today's presentation. I'll briefly talk about our department, the GUDs, and inverse planned fixed field IMRT, and the rapid dark breast planning, and then move to the comparison of the two techniques. We are located in Chania. We're covering the whole island of Crete, and we are treating all cases except total body radiation and pediatric cases. We implementing all modern radiotherapy techniques, and our most common anatomical site that we'll be treating is breast cancer. That's why we have decided to talk about it today. Our equipment involves a Varian Truebeam version 3, which was installed 2.5 years ago. We have Area 16, Eclipse 16.1, and our CT is a Siemens Somaton Go Sim. Our dosimetric equipment involves the Suncheck version 4.3 platform. We have a daily QE3, an IC profiler, just to name a few. The most important part of the department, the manpower behind it. We are treating almost all our patients, simple patients, breast patients, with fixed field IMRT, mainly, and same applies for DABH as well. And we are treating complex breasts, breast with SCF, breast with IMC, breast with axillas, with Rabidarc. And our most common anatomical fractionation scheme is the 15 fractions from import high, and we're also implementing the fast-forward protocol. Okay, I'll briefly touch the GUDs. GUDs are available since Eclipse 13.5. Nimier introduced the equivalent uniform dose for tumors and then generalized it to be implemented in organs at risk. As you can see, this is the formula that describes the GUD, with A being the tissue-specific value which is used to describe the volume effect. A is defined in the range of -40 to 40, acting as upper GUD when A is 1 to 40, and lower and target GUD when it's -40 to -1. GUDs are really useful, but they have some major drawbacks: increased modulation, increased MUs, difficulty to fine-tune the DVHs, and you need extra QA on your machine. But there are some solutions, optimization structures, optimization structures, create your machine, MU objective, just to name a few, and decreased objectives on the photon optimizer. This is a prostate and seminal vesicles plan that we have produced back in 2018 in Norfolk and Norwich University hospitals when we started investigating the use of GUDs. As you can see, we have produced a plan with GUDs and without GUDs. GUDs is the line with the triangles, and pretty much PTV coverage is exactly the same, while organ sparing is massively decreased. GUDs can be implemented in parallel in serial organs and targets as well. This is a 3-dose level head and neck SIB patient that we have planned traditionally and with the use of GUDs. PTV coverage, similar. Spinal cord, DMAX decreased massively. Okay, let's move to how we are scanning our patients. We are using the QFix breastboard with the lung board attached, and we're having the patients with their arms up, and basically we want from our RTTs to have an inclination of at least 10 degrees, ideally 15. Our goal here is to have the sternum horizontal. All simple breast treatment planning, all simple breasts are treated with fixed field IMRT, with zero couch rotation, with non-divergent posterior field edge, mainly 2 fields, maybe 3, maybe 4, but mainly 2. The breast geometry calculator has been developed in Norfolk and Norwich University hospitals. I was part of the team, and it's used to compute the gantry and collimator angles to define the isocenter of the beams used to treat the patient. The calculator is based on the standardization of breast radiotherapy protocol and the casebook paper, which is dated back in 1984 and establishes the use of adjacent beams for isocentric radiotherapy. This is what the calculator looks like. As the user, you have to import a few parameters, and it automatically calculates the rest for you based on the complicated trigonometry. And you can get a glimpse of the trigonometry behind it on the right upper part and how we are placing the isocenter on a gestal patient based on the calculator. Okay, how we are defining the fields. We're defining the fields to include the whole PTV with 2 centimeters of breathing space from the skin surface and 1 centimeter superiorly and inferiorly to account for the breathing motion, as I said, and potential anatomical change. This is what our first optimization looks like. We're using upper and lower for the PTVs, target GUDs for the PTVs, and we're also using upper GUDs for the organs at risk. It is worth mentioning that we are also changing the X and Y smoothing in the photon optimizer to have MLC that move like waves. That's what we do. After 1 or 2 optimizations, we get a plant that looks like this with closed MLC leaves on the skin surface. So we use the skin flash tool in order to open the MLCs, and we're also using the irregular shape compensator to remove any hotspots and shield further the heart when it's more than 0.5 centimeters inside the field. As I said earlier, GUDs increase modulation. This also increase modulation, so you have to monitor the MUs. Don't let it go wild. This is what the final plan looks like. We have shielded the heart further, we have removed the hotspots, and it's ready for our clinicians to check it and assess it. Let's move to the breast rapid track planning. It's a bit more challenging because we're treating patients with IMC, with SEF and axillas, and you have to introduce the breathing motion of the patient when they are treating tangentially. We are doing that with optimization structures, mainly the PTV expansion, and we are also using 1.5 centimeters of pseudobolus covering the whole PTV with minus 500 HUs. We always try to have at least 0.5 centimeters of difference between the PTV expansion and the pseudobolus in order to have, because the photon optimizer and Acuros are dealing better with the scatter. We're using 3/6 triple F arcs for the patient, for the plan, and we are extensively using GUDs. But as I said earlier, GUDs increase modulation, so you have to use the MU objective to decrease the modulation. We are also using multi-criteria optimization to improve the homogeneity of the PTV. After we have assessed the plan, and we're happy with that, we're copying and paste the pseudobolus plan, we remove the link with the plan, and we recalculate the plan. Finally, we normalize the plan to target median as per ICRU 83, and it's ready for our clinicians to check again. Okay, let's move to the comparison of the 2 techniques from our department. All our patients have 2 PSQE methods with similar passing rates, average passing rates, as you can see. MUs, it is worth mentioning that the treatment times is significantly lower in IMRT, mainly because we are using 2 fields with as low as 62 seconds. And homogeneity index is pretty much similar between the 2 techniques. As you can see from the first table, PTV coverage is improved in IMRT, and I would like to emphasize on the mean heart dose. It is really, really low in IMRT, and we are preferring IMRT. And the same applies for the contralateral breast and the contralateral lung. It's really low. We have mainly grade 0 dermatitis in our clinic. And finally, we are using, because we are using static fields, it's really easy for us to correct for potential setup errors, or in this case, not using the optimal upper threshold for DIBH. We have assessed the in vivo of the second fraction, and we found out that it had really low passing rates, and we discussed it among us, and we decided to decrease the upper threshold, leading to increasing the passing rate on the subsequent fraction. This is some reference of today's presentation. the people that I would like to thank for today's presentation for their contribution. Thank you for your attention.